and welcome to PCI London Valves 2025. My name is Tiffany Patterson and I'm joined by Davide Capodanno to discuss the important topic of aortic stenosis and coronary artery disease. Davide, welcome.
Hello Tiffany, thank you for having me.
So I think the question on everyone's minds is, why does it matter?
Well, it's a very frequent situation. No? You refer a patient to TAVI, and then it's calculated that in about half of the patients you will find some coronary artery disease. You will end up with PCI in 10 to 20% of the patients. So it's not negligible at all. But then the question is whether this is an innocent bystander or it's something that has to be treated around the TAVI period.
So I guess that leads on to the next question is, should we be treating coronary disease in patients who are going forward for TAVI?
Let's say Activation was a study run many years ago, and the result was somehow suggestive of some effect of PCI and maybe some downside also, some bleeding, but it was a small study, so it didn't give a definitive answer to the question. But now we have Notion 3. And this is a larger study that shows for the first time that there is a benefit in doing revascularization at the time of TAVI or soon after TAVI. So now I think we have the evidence that somehow assist us and assist our judgment when deciding. And it seems that we reduce the incidence of major adverse cardiac events if we revascularize coronary artery disease in TAVI patients. So the short answer is yes, we should strongly consider to do revascularization.
Okay, and then how do we decide which coronary lesions we should be treating or shouldn't be treating?
Let's say this is the difficult question now, because there are some lesions that are very tight, so more than 90%, and now according to the new guidelines, it's clear that you have to treat this. But of course there are also intermediate lesions that are less than 90%, maybe they are 50 to 90%. And then the question becomes, should we use angiography as a way to judge these lesions, or maybe we can use hemodynamic assessment like FFR, which is always tricky in the setting of aortic stenosis. But there is now the TAVI study that has been presented and it will be soon published that show that there are less events in the FFR guided group. So it seems that now we are entering a new era of studies on how to select the right lesion, and I think this is the next big challenge to understand.
Okay, and so we've chosen our lesion, we know our patient, when do we treat them?
I think this is another topical question because, of course, in order to address this question, we would need a randomized study comparing PCI before TAVI versus PCI after TAVI, and we don't have this information yet. I think now we are somehow facilitated by the design of a new prosthesis because the access to the coronary arteries is less of a concern than in the past, but still it remains a concern in small annuli, in case of misalignments. So we have to think carefully at the time of the TAVI on what are the options, especially because we are now treating younger patients, so they have a long life expectancy and it's likely that they will need PCI later on. So I think that if the PCI is straightforward and can be done at the time of TAVI, this is the way to go. But now that we can really plan a good alignment and we can access the coronary arteries later on, I think staging is not necessarily a bad idea.
Thank you, Davide. That was very comprehensive. So you heard it here, TAVI and concomitant coronary artery disease. Overall, based on the trial data, it's important. We should consider treating it. We should consider treating significant lesions that are potentially FFR positive. And the timing at the moment appears to potentially be more straightforward pre, but we still need to find out if post is also a straightforward option. So thank you very much, and thank you for joining us at PCI London Valves.